So sir, first of all, we would like to thank you that what kind of idea would bring you to book to release, and how it's going to help to the patient in a real world cases on particular cardiovascular patients.
Dr. Kunal, first of all, I must be very thankful to you for asking a very important and pertinent question. This is the first book in the world released by an Indian cardiologist from the Indian continent on STEMI. And this is a textbook of STEMI, which contains almost about 1300 pages and about 175 chapters. And there are more than 300 contributors from India and abroad for this important book. You asked me a question: what was the main drive for writing this book and editing this book, which was a Herculean task, almost complete 1.5 years, and a very, very expensive task. The book is very, very expensive. It is brought in by JP publication, and we really worked hard. See, it's almost for last 35 years, I thought the STEMI care is a real challenge for India and the real world, because 50% of patients still die at home without availing any care. They have a sudden death. In the remaining 50%, when they come to the hospital, there are no protocols. Should they be given thrombolytic treatment? Should they be given angioplasty? Should they go for bypass surgery? There has been a lot of confusion. Everywhere there is a confusion. Everywhere there is a controversy. And I'm sure when we have repeated controversies, ultimately we come to a consensus.
Yes.
So I thought, why not to give a consensus document on the STEMI care, ultimately to improve the morbidity and mortality benefit after STEMI, so that there is a proper protocolization in every EMS in India and the real world. People should know exactly what should I do. For example, I just tell you, if you see in the United States, there are only 20% of the people who are subjected to primary PCI. 20%. In USA, the biggest center in the world. In India, if you go through the data of National Intervention Council of CSI, the maximum number of primary PCI done are in 15 to 17% of patients, with matching the USA. In other words, 80% of individuals are deprived of primary PCI. So we thought, why not to bring in data? And you'll be very astonished to say that we have got a very powerful data from our own country of thrombolytic therapy in STEMI, and it matches the data from various studies which are from Mayo Clinic or from other registry data from the different parts of the world, which is very, very powerful. And it says that pharmacoinvasive therapy is the only therapy which works in the acute care. When I thought of writing, editing a book on STEMI, I thought, why not to bring a consensus? What to give aspirin, how to give clopidogrel or prasugrel or ticagrel. There is always a controversy. Statin, high dose or low dose, beta blocker, high dose or low dose, should we or should we not? In everything, there is a controversy.
Yes.
ARB, should we or should we not? ACE inhibitor, should we or should we not? Similarly, many other drugs like low molecular weight heparin or bivalirudin, similarly, what we call as so many drugs available. Even in the primary PCI, should it be with a thrombosuction? Should it not be with thrombosuction? What are the benefits? What are the single vessel disease versus double vessel disease? Culprit vessel versus non-culprit vessel? So I think there are so many issues. So all the eminent authors and contributors have put their life into it. And it's not me alone, sir.
Yes.
Dr. Kunal, I am very straightforward to you. It is the contributors who have done a tremendous job.
Yes.
And I think this book is going to be released tomorrow, and I'm sure it's not going to benefit our own country, but the whole world. And this is just the initiative, and I'm sure many people should work from now onwards so that they bring more and more data, and ultimately the morbidity and mortality should significantly reduce. That's the main objective of bringing this book.
Surely, sir. So it's a very nice thought on this particular STEMI update, and that definitely it will help to all the upcoming doctors and all the physicians who are treating the myocardial infarction patients, and how this book will change in routine practice of that physician as well.
Sure.
So definitely we are eagerly waiting for for tomorrow that you can release a book, and we can also have update our knowledge on that, how we can go ahead for the ACS patients. So, sir, we have also heard that after this book, you are writing on atrial fibrillation. So, as we know, sir, atrial fibrillation is one of the commonest arrhythmic disorders globally as well as in India. When after the post-surgical and when the patient is discharged from that, but still, it is called as it's one of the under-detected disease. So, sir, what is your experience during your clinical practice? Have you found this kind of the cases remains under-detected, and at a very late age and very late time? The patient comes to
Kunal, I think it's a very important thing you asked me second time. 60% of work has already been done for my next book, which I am trying to bring about 210 chapters. And this is going to cover the overview of atrial fibrillation, the prevalence rate of atrial fibrillation, and the clinical spectrum of atrial fibrillation, the diagnosis, and how to approach and investigate the patient of atrial fibrillation, and the therapeutic intervention, maybe in the form of drug or mechanical intervention. Now there is a lot of data which is coming up, especially for left atrial appendage closure, huge data. And there is a breaking news which was published only this morning. It is submitted for publication in Indian Heart Journal. This is on LA appendage closure, a series of LA appendage closure, first time done in Manipal by Dr. Shetty. So I think this is something very big news, and he said that maybe in patients where we are not able to give acetylcholinesterase or warfarin, or we are not able to give newer oral anticoagulants, does this technology really help or not? So this is going to open, and we have India Live very shortly, and CSI starting from tomorrow. So we have a lot of sessions on this. So atrial fibrillation is the most hot topic, not in India, but in the whole world. So I thought, why not to start something in non-valvular atrial fibrillation, in valvular atrial fibrillation, and in the elderlies, where it's a real problem in India. And every Indian cannot afford to have a oral anticoagulants which are less expensive or more expensive. They cannot even monitor it. So I think there are a lot of issues which need to be addressed. And I thought, why not, again there is a controversy. So again, why not to come to some consensus document and create our own data of what is the prevalence of non-valvular atrial fibrillation, how much is the valvular atrial fibrillation, other causes of atrial fibrillation, how to diagnose them, and how to treat them. And what is the data? Vitamin K antagonist versus newer anticoagulants, how much is the difference, or as compared to our acetylcholinesterase is old or gold? Is it true or it's not true? So I think somebody has to bring a comparison, head-to-head trial. Are they there in different molecules? Whether it is, all kind of issues need to be addressed in elderlies with prosthetic valve, in a pregnant woman, and then in elderlies with TAIA, with a stroke, with a prosthetic valve, with post-angioplasty, post-MI, cardiomyopathies, LA thrombus, LA appendage thrombus, without LA appendage thrombus, all those issues to be discussed. And I'm sure with the help of all the authors and contributors, we will be able to reach to some conclusion in the years. This is just a stimulus, so that we all contribute more and more, and ultimately reduce the morbidity and mortality of atrial fibrillation in our setting. So very shortly, maybe by next conference in Kochi, we are going to release this textbook on atrial fibrillation for the first time in the country again.
Yes, definitely, because also as a physician, we are also searching such kind of the data, but it's not available very widely. So this kind of a single document consensus will definitely help us a lot. So, sir, definitely in atrial fibrillation, as you have talked that regarding a management part, the oral anticoagulants are definitely stayed as the main part because of the stroke prevention in atrial fibrillation. So far, acetylcholinesterase, warfarin, these are the old drugs, but still they are called as a gold drug. So what you have found that this drug, and now very recently the newer oral anticoagulants like rivaroxaban, apixaban, dabigatran, these are available since last 3-4 years in India. So have you find any kind of difference between older versus?
See, it's a very important point, whether it's a rivaroxaban or it's a dabigatran. We have used in almost about more than 40 or 45 patients so far. And I can tell you, there was one patient who came to me who was a very eminent dancer, national dancer. And he was on dabigatran prescribed by Dr. Samir Srivastava in the Fortis Hospital. And he came to me with a severe colicky pain in abdomen. Severe colicky pain in abdomen. And he already had a TIA in the past and he had atrial fibrillation. When I saw the patient, and I straight away said that this patient has got a mesenteric arterial embolism because of atrial fibrillation. So I immediately called Samir Srivastava. He is already on dabigatran. Has he received acenocumarin before? He has got atrial fibrillation on dabigatran. So he said he received acenocumarin before, and since he is elderly and he is not having a compliance for the PT check, so I thought to put him on dabigatran. So he is getting the episodes again. So you can change if you want again to acenocumarin. And I did that. When I did that, patient again had a recurrence of pain. Ultimately, I referred the patient to Dr. Balbir Singh, and he found he had LA appendage thrombus. Now this patient is ready for LA appendage closure. So what I mean is, we have to have a strict criteria of selection. Dabigatran is very useful, no doubt about it. Rivaroxaban is a very useful drug and safer because we don't need to monitor them repeatedly by PT or INR, which is a very difficult task in India, but it's expensive, no doubt about it. But it has got a lot of value seeing our elderly population, and it has a lot of benefits, especially in those where we can't give other oral anticoagulants, vitamin K antagonist, and where PT and INR facility is not possible. I think the future is going to open, but we have to select our patients. And I am telling you very frankly one thing more today. LA appendage closure is also not the answer. Because there are some people where you find LA appendage thrombus, maybe 80%. But 20% of patients, they may even have a LA thrombus and that doesn't form. Maybe just a Role formation, it may embolize again. So I think we need to have some therapy like novel oral anticoagulants. It has a huge scope in the years to come. And I'm sure we have to work on it. And once I collect more data in next 1 year, I'm sure I'll be able to answer your questions as to which is the best one. If I compare vitamin K antagonist with the NOACS with LA appendage closure, or is there any head-to-head trial of the various agents, dabigatran with versus rivaroxaban, and then let's see which is the best agent and which is stood the test of time. But there is a lot of debate, and it's a very, very hot topic, not only in India,
globally as well.
Globally. So we are working on it, and I'm sure with the help of each and every one of you, we will be able to reach to some consensus in after a year or so.
Surely.